Welcome to the Thinking in Between podcast, where we explore the borderlands between health and social science. In each episode, we invite someone working at these borderlands to explain three big ideas that have influenced their thinking and research. My name is Stephen Hibbs, and I'm a doctor by background, but currently undertaking a PhD using a social science approach. And today I'm joined by Elspeth Davies, who is completing her PhD at the University of Cambridge and will soon be taking up a postdoc at the University of Oxford. So Elspeth, thanks so much for joining us today.
Thank you so much for having me. It's lovely to be here.
So do you mind just to start with telling us a little bit about your research journey so far?
Absolutely. So I often half-jokingly say that I did a PhD by accident, in that I was finishing my undergrad in social anthropology and was actually looking to get what at the time I thought to be a real world job. So I was looking at kind of civil service, social work, things like that. And at the time, Cancer Research UK were advertising a PhD in social anthropology, looking at cancer early detection. And my undergrad was in social anthropology, and I had an interest in cancer early detection. I had an early stage melanoma as a teenager,
right,
and became really involved in the kind of cancer charity world as a result of that. So it kind of felt like it was meant to be in some way, and I applied and they offered it to me, to my surprise. So I thought, oh, here we are. And that was January 2020, and then I started in October 2020 in the depths of the pandemic, and it's taken the last 4 years to get it finished.
Okay, wow. And you're just on the cusp of finishing, I understand.
Yes, I will be submitting next week if all goes smoothly, touch wood.
Fantastic,
yes.
Fantastic. Well, thanks so much for joining us today. And I'd like, first of all, to ask you about the first idea that you've brought. And this is a book chapter by McDonald called Bodies and Cadavers. So could you start by telling us a bit about what this chapter is all about, and then how it's shaped your thinking and research?
Absolutely. So the chapter, very broadly, is about how medical students learn anatomy by dissecting cadavers. And Marion McDonald, who, for context, is my PhD supervisor, and that is how I came across the article. Marion is using this piece of work by Bruno Latour. And in Latour's work, he's describing how trainees in the perfume industry in France become able to distinguish between increasingly subtly different fragrances. So they're learning to notice differences between scents that they wouldn't have been able to detect before. And Marion McDonald applies this work to the training of medical students, and she's arguing that these students are also learning to be affected in new ways. So, for instance, they're learning to turn kind of people or bodies into anatomical working objects. They're learning to distinguish between veins and arteries, for example. So they're learning to see differently, such that what I, as someone who's not medically trained, might see as a kind of bloody mess during dissection becomes a detailed map of organs and tissues. So what both Latour and McDonald are arguing is that it's not that these people are subjectively experiencing some kind of objectively given world that exists out there, but rather that they are themselves acquiring new bodies at the same time as the worlds around them are being registered in new ways, if that makes sense.
I like that. And so at the time you were reading this, how did it speak to you?
So I found it incredibly useful for thinking about how research is a highly embodied practice. So it's not just that we produce research, but research also produces us in really fundamental ways. And it became particularly useful when I came across the notion of overdiagnosis, which the definition of which is highly contested, but a simple definition might be overdiagnosis as the idea that some cancers will never progress to cause harm and therefore are being diagnosed unnecessarily. So this was interesting to me because the vast majority of my fieldwork was with researchers who were working to facilitate cancer early detection, specifically of esophageal cancer, or cancer of the food pipe was what I was working on. I then attended some conferences and came across this whole group of academics who were really, really critical of the cancer screening interventions that I'd become really familiar with, and that I'd come to associate so much with hope because of the academics that I had been working with before. So at these conferences on overdiagnosis, these kinds of early detection interventions at times are treated with this real suspicion. The kind of the value of, for instance, diagnosing and managing cancer risk becomes called into question. So you see that people at these conferences have, in Marion's words, in Marion McDonald's words, have learned to be affected in a different way. They've learned to see in a new way. So an intervention that might be seen as hopeful somewhere else becomes harmful in this field. And these researchers have acquired a new body in the process. So they somatically feel that very differently. I found Marion's article really useful for highlighting this kind of embodied nature of research. Knowledge is not only kind of read and understood, but it's felt and it's lived, and it kind of fundamentally changes the bodies in which we exist, particularly in the field of cancer prevention where I work, because everything is so highly emotionally charged. So this kind of work can have really, really effective consequences.
Can I ask for you personally, what the research you were doing, which sounds like went from also moved towards more of a critical lens over the course of your research, did that do something to change your sort of body, your I don't know, whole stance towards what you were studying?
Yes, that's a really great question. I was going to touch on that in my answer to the next bit.
Let's keep it for that then.
Yeah.
That's excellent. Fantastic. I guess the other thing that it raises for me is, in the perfume example, I guess that people are very aware that that's what they're aiming to do, is to become attuned to something in a completely new way. But in the application here, how often are people like the medical students looking at cadavers, or the other ways in which this might be applied to researchers, how often are people aware that they are, like perfume testers, developing a new way of seeing and understanding the world, and how often is that happening without their knowledge?
Yeah, that's an interesting question. I suppose with the medical students, there is at least some awareness that over the course of their training, they are learning to see things that they couldn't see before, even if they wouldn't put it in those terms. You know, a student on their first day of medical school experiences a cadaver dissection differently to a student on their last day. And that is an intentional training process that they go through. Whereas at these conferences, I think, as you point out, it's much more subtle, and perhaps people aren't, or maybe they do go to these conferences in order to become trained in a new way of thinking. Maybe they don't. And then that seems like an important distinction between those two examples.
The other thing I'm interested in is there a way in which you stop being able to see certain things as you, so something you could have seen on day one, you no longer can see by the end, either in the case of the medical students and who see a body, who are now a different body encountering this body. Is there a way that in all of these processes you lose the ability to see and detect, your body almost loses that ability that it had at the start and it doesn't have at the finish? Do you think that ever happens?
Completely, and that links back to a conversation we had before we started recording about the kind of jargon that surrounds social science and theory. And I think one of the challenges is that many of us who are trained in these kinds of knowledges and disciplines become unable to see that what we're saying is not accessible. I made a speech last week at a wedding with my twin sister who's not an academic, and we wrote the speech and she said, "Elspeth, these are not words that normal people use," and I had become unable to kind of shift out of that academic mindset. So I guess that's one example of how we acquire new capacities. We also lose particular capacities in important ways.
Yes. Wow. Is there anything else you want to say about this chapter before we move on to your next idea?
No, I'm happy.
Okay. So the second idea that you've brought today is an article from Medical Anthropology Quarterly by Yates Doerr called Reworking the Social Determinants of Health, Responding to Material-Semiotic Indeterminacy in Public Health Interventions. So would you mind just telling us a bit to start with about what this article says and then what it did for you, how it spoke to you.
Yeah, so it's a very, very wordy title. Essentially what she's doing in this article is comparing the notion of the social determinants of health, which has become really kind of widely used in recent years. She's comparing that with an anthropological approach to what she calls the sociality of health and illness. And she does this by drawing on her ethnographic fieldwork in the Guatemalan highlands. And in essence, the article is a critique of the social determinants framework, and she suggests that it might uphold or even worsen the conditions of inequality by adopting this notion of health that has seemingly been predetermined by distant experts. So instead, Yates Doerr is trying to talk about how she's trying to ask how health comes to matter in people's lives. And there's lots of interesting examples in this article. So for instance, at one point, she talks about a mother in Guatemala describing the complex ways in which her health has become entangled with others, both of her children and her loved ones around her. And Yates Doerr makes a comparison between that complex, messy, interrelated notion of health and the notion of health that's used in the social determinants of health model, in which health is located within a particular person. And she's pointing out how those are quite different things. The article is suggesting the benefits of using an approach that doesn't assume what health is in advance. And I'm putting health in scare quotes there for the listeners who can't see me doing that. So avoiding defining health in advance, but also importantly, working with the communities that we're writing about to respond to the effects of carrying out research. So there's this, I think, fabulous bit at the end where she talks about not just doing surveys, but looking at what a survey does. So following the consequences. So for instance, asking who made the survey, how did they do it? What kind of knowledge does this survey enable or disable? And what are the consequences of the concepts it mobilises? So for instance, one thing that the social determinants of health framework does is it correlates a person's number of years of education with their health outcomes. And instead, Yates Doerr is asking, what do we mean by education? What kind of education? What types of education are valued or ignored? What are the effects of this value system on people's lives? So she's suggesting that these kinds of concepts like education are not just describing realities in the world, but they're also enacting them, if that makes sense.
Yes.
So I read this very early in my PhD, in the first year, in the depths of a COVID lockdown. Thought it was absolutely brilliant, so clear, so engaging. Came back to it recently and realised that it was somewhat prophetic for me, in that when I attended these conferences on overdiagnosis that I mentioned earlier, I was exposed to a particular body of research that suggested that melanoma in situ, which I mentioned having had earlier as a teenager, is very often overdiagnosed. So it's very often diagnosed and treated unnecessarily because it's highly unlikely to progress to cause harm. And I learnt to be affected by this research in a very particular way because I came to understand that my cancer might have been diagnosed and treated unnecessarily, which was a really complex and messy process. So I think this article both inspired and really helped me to write about this process of not just doing research, but looking at what research does to all kinds of people, to the participants we write about, and also to ourselves as researchers. So in my case, this particular body of research, at least to some extent, transformed me from a kind of simple cancer patient into a potentially overdiagnosed person. And that, I think, is a really ethically complicated thing, given that there's no support groups for people who, well, that's not true. There are some support groups for people who understand themselves as overdiagnosed with particular cancers, but not melanoma. And these groups tend to be quite controversial. So in lots of ways, it was a difficult and isolating experience, and highlighted the importance, which is one of the points that Yates Doerr is making, the importance of understanding research as a kind of messy and looping process, and much more messy and looping than is implied by the kind of linear process of procedural ethics in which you apply for your ethical approval, you point out what some of the harms might be, they approve it, you do the research, and maybe you disseminate the research, wonderful, that's that. Instead, I think we need to think about it more as a kind of web of complex consequences in which we have to find ways to continuously follow what we're doing.
Yes, yeah, wow. Because I guess when you were applying for your ethical approval, yeah, it was not going to come up of, is something going to make me rethink my own autobiography and my own position of, as you say, kind of almost some of what led you into your interest in taking a PhD in the first place.
Yeah.
It's almost like the snake eats its own tail or something like by there. And yeah, can you say a bit more about that, of like that journey for you of trying to reappraise your own story with that?
Yes. I mean, I think at the time it felt like having the rug pulled from underneath my feet. I think that obviously being diagnosed with a cancerous disease as a teenager is very difficult and has all kinds of life-changing consequences, particularly because of the way that notions of risk are mobilised. You're told that you're at risk of having melanomas in the future and you have to practice surveillance, and people often experience really kind of significant and long-lasting consequences following a diagnosis like mine. So to then be at this conference and be told that, there's a particular paper that suggests that there's between a 90 and 95% overdiagnosis rate with melanoma in situ. So the odds that the kind of malignant cells that I had removed, the odds that they never would have progressed to cause harm, according to that paper, are really quite high.
Right.
And I didn't know how to make sense of that, particularly because that's not, overdiagnosis is not a widely understood issue. So when I mentioned this thing to the people around me, I mean, they thought I was mad.
Right.
And because we have the dominant idea of cancer is as this disease that progresses quickly, uncontrollably, and is often fatal, to then talk about overdiagnosis is to present people with like a fundamentally different idea of what cancer is. And it means it can be really hard for people to take it seriously or to kind of accept that it's a reality. And so I had people say to me, so I would express a concern about overdiagnosis, and they would say, well, at least you're not dead, because the idea is that all cancers could kill you, and therefore like thank goodness that you're not. And often that perspective comes from people who have experienced like real horrendous tragedy as the result of malignant diseases, and I think we have to take that seriously. I think there are also important questions, to ask about overdiagnosis as a phenomenon, but also about how we talk about overdiagnosis, which I think is a conversation that we have had much less. So this comes up also around PSA testing for prostate cancer.
Right.
We need to find ways to talk about the fact that the majority of prostate cancers will never progress to cause harm. We have to find ways of having that conversation without quite fundamentally damaging people's trust in the biomedical endeavour. Yes. And that's a very difficult thing to do that I think we've not nailed, and I think currently we've not dedicated much time or attention to thinking about that aspect. We're thinking about overdiagnosis, but less about how we talk about overdiagnosis. And so that is one of the things that I wanted to look at in the PhD and hope to look at in the future as well.
Wow, there's a lot I want to ask you about. I guess to start with, just reflecting back on this particular paper, one thing I like is that it sounds like it's not, it's sort of challenging these, I think I'm using the word rightly, totalizing concepts of something like education or something that's quite big, that feels solid, and it feels like it's anchoring way of seeing the world, and it's saying these things, what you mean by that may not be meaningful to someone else in a different context, and therefore starting with these block set of lenses of now trying to these kind of monoliths of the things that matter, and how does this get affected by these however many things, but actually there might be some that become really pertinent to an individual or a community that just get completely missed. I'm wondering if that kind of, I don't know, challenging of a totalizing concept came up in your research at any point of something that was like a taken for granted category, but that there was another way of seeing that sort of turned it on its head at all. I wonder if that came up at any point for you.
Yes, I suppose it comes up around the notion of risk in biomedicine, or at least like in kind of dominant discourse around biomedicine. I think in lots of research there's much more nuance, but like the messages that get communicated clinically and publicly are, for obvious reason, simplified. And it means that we get this idea that risk is bad and we should do everything we can to reduce it, and we're responsible in important ways. We're responsible for reducing our risk. Obviously that is turned on its head in the overdiagnosis space, where they're saying, actually maybe reducing risk in itself has harms. Maybe the risks of risk management are worse than the risks of not carrying out risk management, if that makes sense. So I think I approached the PhD with this idea that risk is bad and needs to be managed, and actually that was turned on its head. There's also this other aspect which my work has touched less on, but I know colleagues have written about it. I have two colleagues, Ignacia Artiega and Kelly Fagan-Robinson, have written about so-called hard-to-reach communities. So specifically, they worked with rough sleepers in East Anglia. And they've written about the idea that for some people, attending cancer screening or managing cancer risk is not in the realm of possibility. And they have this brilliant quote about if your sleeping bag is on fire, you cannot go to see the GP about your persistent cough. It's much neater than that.
Yes.
So once again, this idea that like risk should always be reduced is totally disrupted, because it's not that cancer risk is irrelevant to these people, but the kind of daily realities of the material life do not remotely facilitate that kind of risk reduction at present. So yeah, I suppose risk is one concept that I've sort of tried to dig into.
So I'm wondering as well if you could say a bit more about your thesis and your doctoral research that you're just finishing, and a bit about how these questions around risk, how they became pertinent in your research. So very broadly, I knew that the thesis was interested in this shift that we've seen both in the NHS and in many other healthcare systems since the second half of the 20th century, where we've moved from treating people who feel unwell towards treating people who might maybe feel unwell in the future, and trying to prevent illness from developing. The thesis came to be about how notions of risk come to be valued differently in different settings. So it was mostly working with early detection advocates, researchers, research nurses, patient advocates who were pushing for the development of new kinds of cancer screening, specifically in the field of esophageal cancer. But also, as mentioned, I ended up in these interesting spaces where people were incredibly critical of all kinds of cancer screening interventions, and particularly of this idea that it is moral, it's right, it's valuable to diagnose risk and manage it in the hope of preventing future cancer. So risk comes to mean and function and be experienced very differently in different spaces, and the thesis is trying to make sense of how that happens very differently. Thank you. Is there anything else you'd like to say about this idea before we move on to your third idea?
I wanted to mention, so earlier I talked about this fear that talking about overdiagnosis or the complexity of cancer screening or medical interventions more generally, the fear that doing so could damage people's trust in complicated ways, and just needs to be done really carefully. It's not that I don't think we should do it, but I think we should think about what we're doing. An interesting thing that happens in these fields in which people tried to question the inherent value of medical interventions. And I saw this in my fieldwork, was that these were academics from reputable universities publishing in peer-reviewed journals. Some of them, in some spaces, became accused of being conspiracy theorists.
Right.
Which, as an anthropologist, was so incredibly fascinating. I mean, terrible for my peers who were in this really stressful situation, but I was fascinated in how the boundary between legitimate critical thinking and conspiratorial thinking was really fine and had to be walked very carefully. And then, interestingly, I discovered how thin this line was myself when I published this very short article about overdiagnosis and melanoma, but specifically about the harms or potential harms of talking about overdiagnosis and my own experiences. This article briefly, not very long, but briefly circulated in what some might call, including myself, some might call conspiracy theory Twitter. Okay. And that people were sharing it. These were people who were also sharing perspectives that I personally would not be on board with. Some kind of extremely right-wing beliefs. And then there was my article circulating in it, which was ethnographically fascinating, horrifying.
Right.
But interesting, an interesting example of how we become entangled in the fields in which we work.
Wow, that's fascinating. I guess it's just such an idea that generally people can unite around of we want there to be less cancer, that to come in with any narrative that complicates that doesn't, it's not actually against that, but it does complicate it. Yeah. I guess naturally leads to strong reactions, but that's and I have a lot of sympathy for that. I think one of the things that I argue in the thesis is that it's these simplistic narratives about the importance of cancer early detection that for some people make life livable when presented with this really hugely feared disease. It's this hope that makes life livable, and that's, for many people, that's why we go for screening. It's because it makes us feel better. We think it might help prevent this horrible thing. And then so to have people challenge that or threaten to take that away, of course, provokes incredibly strong reactions. And that is why I think we should have nuanced conversations about overdiagnosis, but I think we need to be incredibly careful about how that happens. Wow, thank you. So I'm going to move on now to ask you about your third idea, which is a method. It's the method of Facebook ethnography, which is really cool. I've not seen those two words together before, and I'm really intrigued to hear about it. So could you tell us a bit about your own experience of using ethnographic fieldwork in Facebook support groups, some of the opportunities this raised, but also some of the ethical issues that came up as you did that?
Absolutely. Yeah, so I wanted to talk about this because I think it's methodologically interesting, but also highlights something important, perhaps about the changing practices of care in the NHS, which I'll get to. So I joined support groups for people who have a condition called Barrett's esophagus, which is often described as a pre-cancer or risk state for esophageal cancer, for a type of esophageal cancer. And I did that because I was mainly working on this screening test that was looking to diagnose Barrett's esophagus. So it was a test that is in trial that might be used to screen people for Barrett's. So I was asking questions about, what does it mean to live at risk of esophageal cancer? For context, this was in 2021. So we're in the depths of the pandemic, basically. We're beginning to think about what might be called post-pandemic life, but there were winter lockdowns and everything had been really, really affected by COVID. Right. So groups that previously were in person were now meeting online, and sometimes that was happening on Zoom. But also we had these massive Facebook groups. So I did what might be called participant observation in both these types of groups with the aim of following the consequences of this particular risk diagnosis out of the clinic and in some way into everyday life, given that I couldn't go into people's homes because of the pandemic. So it was trying to get at these questions of the everyday realities. And it proved to be a really rich site of ethnographic data and highlighted some really interesting issues surrounding, for instance, so these people are diagnosed as at risk of esophageal cancer, and they're offered regular surveillance with endoscopies, usually every few years. A thing that came up repeatedly in support groups was that they felt that their kind of everyday embodied realities had been overlooked in these efforts to reduce future risk of disease. So they had often really uncomfortable symptoms of acid reflux, which is thought to cause Barrett's esophagus. And they had sometimes these really high levels of fear about future cancer that was unmanaged. And these two concerns became so clear in the support groups. Right. So it was really useful for highlighting these things that weren't arising in the clinic, but really were appearing in everyday lives. The Facebook groups in particular were fascinating because they were so unbelievably active, or at least some of them were. So there were a few that had more than 10,000 members from all around the world. They were active almost constantly, so with people posting new posts, but also commenting on each other's. And that's fascinating, particularly when we consider that in general, Facebook usage is dropping. And yet the membership of these groups, specifically in Barrett's, but I think with other health conditions as well, appears to be increasing. At least in the context in which I was working, a strong driver of this seemed to be that people couldn't get to see their GP, or they felt they shouldn't bother their GP. So instead of going to see their kind of primary care practitioner, they were going on Facebook to ask these questions. So the location and the type of care they were looking for had changed suddenly. Which was really interesting to me, particularly in the context of COVID and looking at how these bodies that were deemed to be at risk were learning to live with that notion of risk, but not using kind of conventional medical channels because they felt they didn't have access to them and sometimes really didn't have access to them. These spaces are really interesting because, so in the Zoom group, sometimes there's a nurse present or an endoscopist present maybe. On Facebook, other than in one group, most of them didn't have any healthcare professionals present.
Right.
Lots of them had what I would call patient experts who were so highly educated, so active, so wonderful in so many ways. And lots of these groups were really highly regulated and managed and moderated. Not all of them were. And I think one of my concerns was that lots of clinicians were just totally unaware of how huge these groups were and how important they were to some patients. And yet they were just so incredibly, some of them were not carefully managed, and therefore there's a concern about things like misinformation.
Yes.
And I think if we look to the future where we've got an NHS that's really struggling, but also an NHS that wants to diagnose more people as at risk of cancer and other diseases, there seems to be a tension there between turning people into patients on the basis of future risk of disease and also perhaps not being able to provide them with all of the care that they might want. And I think what's happening and what may continue to happen is that these people will move towards other sources of care, for instance, on Facebook. So I mentioned that doing fieldwork on Facebook has kind of methodological issues as well, particularly ethically, because you're essentially doing fieldwork in a public space, even though, so lots of the groups are closed, you have to ask to join them, but anyone can ask to join them.
Right.
And if it's got 10,000 members, it's not a particularly private space at that point. So it's not like I could ask everybody in that group their permission to observe what's happening. And other kind of ethnographers have written about this and have taken different approaches to kind of inform consent in that sort of huge setting. My approach was that I did write posts introducing myself and saying what I was doing, but I assumed that the vast majority of people in the group would not have read those posts. So I invited particular people to be interviewed by me, and those people explicitly gave their permission for me to read and use their posts in my research. There was another problem there in that potentially their anonymity could have been at risk, in that you can, if I'd have used direct quotes from their posts, in theory, if you could do a copy and paste search thing to find out who these people were, which I didn't want to happen. So I changed the wording, only in little ways, but hopefully to make it less findable. And then so other than these people who gave explicit permission, I was reading all these posts, but they were just kind of generally informing my insights, and I wasn't directly using them in my work. But this experience of being, particularly in the kind of the winter of 2021, we were in and out of lockdowns, and yet I was able to do field work, thankfully. It really raised questions about what the field is, who accesses the field, what fields they access, how they access them, which is important both in the context of, for instance, disabled researchers or researchers with caring responsibilities, but also in a post-pandemic world where we know there are events that have the capacity to disable all of us, or in particular ways. So I think COVID offered lots of us the opportunity to think really expansively about ethnography and what it could or should mean.
Wow, no, that's fascinating. I guess kind of circling back to your first idea about how the spaces that you're in and the sort of training that you do changes you as a person. I guess what I'm interested in now is that you've done this Facebook ethnography, and that gave opportunities that probably wouldn't have been possible otherwise. But I'm interested in now, as you look to what you're going to do next, either in this postdoc you've planned or in the future, have you changed now as a person such that is, you want to be doing digital, like Facebook type ethnography, or is there still part of you that feels more drawn towards like being physically in a room with people, or kind of participant observing offline, I guess? I'm just interested to know for you where you stand on that now.
I think historically, or at least pre-COVID, there has been this sort of hierarchy between what might be called like working in the real world, quote unquote, and virtual ethnography. And I think maybe there has been a sense amongst some ethnographers that we just can't quite get the experience of being in person.
Right.
And while I agree that it's a totally different experience, I really don't see one as better or worse than the other. And being able to do my field work on Facebook, to come back to the Yates Doerr article where she talks about like how does this method make particular kinds of knowledge possible? It facilitated kinds of knowledge that would just have been impossible in person for various reasons. So I guess I would love to do it again. It would depend on the questions that I was asking, but I don't see one as inherently better or worse than other. Different kinds of pros and cons in each.
And do you think, because I completely agree that from a sort of methodological rigour point of view, there's not a hierarchy, but maybe I'm more interested, I guess, in terms of just personal enjoyment and of, I guess, the thought sometimes of the amount of time one spends like on a screen or kind of on a computer, and maybe sometimes other forms of fieldwork allow you to get away from that for a time. Just more in terms of like your tastes rather than like your rigour. Would you? Is there any difference to them for you now, or do you think again they can both be as enjoyable as each other? There were periods where I was spending a lot, like many hours a day on Facebook. And to go back to Marion McDonald's language, I acquired a body that experienced headaches when I looked at screens. Right. That was definitely a thing. Although this was in pandemic times, so I was looking at screens for everything I did. So I can't entirely blame my fieldwork. I suppose I was lucky in that I was split between working in the Facebook groups, and I did fieldwork in a clinic where this new kind of esophageal cancer screening was being tested. It was a mobile clinic and it didn't have running water. So one of my jobs was to kind of fill up big tanks of water, and it was a very physical job. I was working with people very much in person, using my body in a different way. So I guess spending so much time on Facebook was counterbalanced by being very, very active the rest of the week. Perhaps that helps. But I think there's lots of people who that kind of field work is not accessible to them, whereas being at home on Facebook is wonderfully accessible. And I can see a future for myself if I have kind of more caring responsibilities where Facebook becomes a really, really appealing option. No strong preference, but maybe I would get those glasses that block the blue light at some point in my life. And just a related question on what you said there about the mobile clinic and that kind of role you're able to fulfill of filling up the water and bringing it back. Like those are, in my experience of fieldwork, those are quite satisfying, where you find little ways of just doing something that's not observing, and I'd be interested to know if you found anything like that in your sort of Facebook component, whether there was any either that you've done or that you've heard of other people doing that's the equivalent of filling up water to bring back, to kind of find I don't know if it was like a bit of a like nuts and bolts helper role alongside the research role, or be interested to hear you speak to that.
Yes, that's a really good question, and one that I struggled to answer because I didn't want to offer, for instance, to moderate the groups, because the practices of moderation were really interesting and messy. I was interested in how they worked.
Right.
And I mean, perhaps one way of understanding how they worked would have been to practice them myself, but I was nervous about doing that. I guess the only equivalent was so people knew who I was and what I was doing, or at least some people did. And there were moments where people had questions about what does the literature say about long-term usage of PPIs, for instance. And I would be very clear that I'm not a medical professional, this is not medical advice. I was, at the time, really familiar with that body of literature.
Right.
And one of the things I could do was be like, here are 3 articles that have been published in the last 5 years. This is what they might suggest, but also, like, please see your GP.
Yes, yes.
So maybe that was how I participated. But it was difficult because I don't have Barrett's esophagus. So it's not like I could share my own experiences. And that definitely did limit the extent to which I was able to fully participate in those spaces.
Yeah. Thank you. Is there anything else you want to say about this third article, or this third idea, before we finish?
No, thank you.
Well, thank you so much, Elspeth. It's been really fascinating speaking about all 3 of these ideas and how they've, I guess, led to quite a surprising PhD journey, both in terms of what you thought you were going to answer and look at, and also how you ended up going about that. Thank you so much for speaking today.
Thank you for having me. It's been such a joy to meet you.
Thank you everyone for listening today. This has been Thinking in Between, and we'll be back with another episode very soon.